we are now starting. Basically, we have already done most of the work on pulmonary pathologies, but I've added some photos, some of them from the FMF website, some of them from our own archive of library from our units. So what I've done is to just try and illustrate what we discussed last week, starting with the bronchial atresia, where we said we're going to see an enlarged lung. So this is how an enlarged lung will look like. It will be enlarged and hyperechoic, as you can see on the screen here. So this is how you'll be able to recognize bronchial atresia using ultrasound. So look at the lung, and the bronchial trees are not visible in this image, but sometimes you may see anechoic structures within the lung. And this is the heart. You can see squashed to one side because of the dilated lung tissue here. So this is what we mean when we are saying this mid-layers now shift. That means all the mid-layer structures are pushed to the side. So that's bronchial atresia. So like you said, chromosome abnormalities, agenesis syndrome occurrence is not increased here. And every 4 weeks scan, the perinatal outcome is not good. High perinatal mortality for this couple. So discussing termination of pregnancy is a viable option when managing these patients. Then the bronchitis, again, it's just a rundown of what we said last week, but now we've added images to aid in terms of understanding. This is a section of the baby here, slightly parasagittal. We are more to the left here. So as you can see, the stomach and the kidney here. So the image we normally use to assess the diaphragm, that's the image we are looking at. So we can see that there's a cyst within the lung tissue here, a solitary cyst within the lung tissue. This is what we mean by bronchogenic cyst. Yeah, and you can see that the surrounding lung tissue looks the same here. It's quite homogeneous. It's no alteration in the echo density of the surrounding lung tissue. So if you see a cystic structure, before you say it's a bronchogenic cyst, because the bronchogenic cyst is possibly the most innocent cyst of the cyst that could occur in the lungs. So just make sure that the echogenicity surrounding that cyst is normal, so that you rule out that differential which you will see just now. Again, hospital neonatal intensive care and pediatric surgery, that's the place of delivery. So depending, no, I don't think this is for instance of chromosome abnormality is not high. This is not for bronchogenic cyst, because if it is solitary, it should be a problem. Then I think my presentation is mixed up a little bit. Let's see. Yeah, it's mixed up. So yeah. So this is more for bronchogenic cysts. Sorry about the other stuff. I think it was for the other for bronchial atresia we started. So this is bronchogenic cyst here. So for bronchogenic cyst, the outcome is not bad, and babies are usually asymptomatic. Yeah, but if there is evidence of bronchial obstruction from the cyst, an exit procedure may need to be done. But generally, the bronchogenic cyst, the outcome is okay. Then chaos, we said, is called congenital airway obstruction syndrome. We already described it, and we learned that it could be due to the agenesis or stenosis of a segment of the upper airway. It could be the trachea or at the level of the larynx. And the features are more evident after 16 weeks. There is massive enlargement and hyperechogenicity changes seen at the level of the lungs. This will result in compression of other structures in the thorax. That includes the heart and also the vascular tree. This will result in the and vascular compromise, there may be ascites. And we also said there may be association with Fraser syndrome, which we said it's an autosomal recessive with a 25% risk of recurrence. And in this condition, we're going to have microthymia, fascial clefts, tracheal atresia, and bilateral renal agenesis that defects in syndactyl or polydactyl. This is how it appears. You can see that the wall chest looks echogenic due to the lungs, which are very much dilated and engorged with fluid. These are the vascular trees and some of the airways here at the center. So yeah, so normally the heart is quite compressed in this condition. Then it's just a quick revision. It's a lethal condition, so that offering termination is termination of pregnancy is another viable option in this case. Then we have CPAM. CPAM, we also said it can also be called CCAM, congenital cystic adenomatous malformation. However, the common name now used is CPAM. CPAM means congenital pulmonary airway malformation. Fairly common, and we said there are two types, which is 1 in 4,000. There are two types. There's a solid or a microcystic or a macrocystic one. As you can see, this is a macrocystic from the FMF website. There you can see the big cysts. Normally, if the cysts are big like this, there's going to be mediastinal shift, and the heart will be pushed to one side, as you can see. And this is microcystic, tiny cysts, which sometimes appear like it's solid. It pushes the heart again, cause mediastinal shift, pushing the heart to the other side. So that's microcystic. Due to this compression effects, the baby may end up with either hydramnios or polyhydramnios may appear in this kind of situation. Again, it's a quick revision of what we covered last time. Yeah, so good survival in 95% of the cases, but whenever hydrops appears, then the condition becomes lethal. The risk recurrent, no increased risk of recurrence unless this Fraser syndrome then becomes 25%. Diaphragmatic hernia, we have seen quite a number of diaphragmatic hernias, but what you are going to see at the level of the thorax is that their heart is pushed to the other side, or is displaced from its usual location. And if it is a left-sided hernia, you are going to see the stomach in the thorax and some bowel structures. Sometimes the liver may also come in the thorax. Congenital diaphragmatic hernias are very common, and they present with polyhydramnios, and they are commonly associated with cardiac defects as well. The genetic syndromes that are common there, we have Pallister-Killian syndrome. We may also have some tetrasomies like tetrasom 12P, and also French syndrome is common in this case. So we talked about the lung-head ratio in terms of prognostication of the disease, so that we call it severe if the lung-head ratio is less than 25%, moderate if between 26 to 45%, and mild if greater than 45%. So how we come up with the lung-head ratio is that we do take two measurements. Let me just illustrate it here. So we take two measurements of the remaining lung, like this. Then if we go to perinatology.com, there is a formula that will allow you to input these two measurements. so that the area of the remaining lung can be calculated, or the area of the visible lung can be calculated. Then, of course, the area obtained is going to be divided by the head circumference to get the lung head ratio. So this is how the lung head ratio is calculated in congenital diaphragmatic hernias. And the two-dimensional measurements are inputted into the perinatology.com formula website where the calculation will be done. So, yeah. We also mentioned that there's no fetal. Fetal means fetoscopic endoluminal tracheal occlusion. A lot of work has been done on this. And normally the time for insertion is 26 weeks and it's removed between 34 to 36 weeks the balloon. We said the insertion of the balloon will allow the compressed lungs to expand and grow. This is the baby a chance. So in terms of prognosis, if it is isolated, survival is 15%. If the disease is very severe, like less than 25% of the lung head ratio. If it is moderate, it is 50%, and if the disease is mild, then the survival is greater than 90%. However, it is lethal in associated trisomy 18. As you are aware that trisomy 18 is highly lethal condition. Delivery, again, the right to hospital. We don't say we would deliver them in Uguero, then we would transfer them to Harare when the baby is born. It's in utero transfer. This is very important to the surgical units. So there is morbidity associated with the survivors, which include developmental delay in up to 30% of the cases, especially those requiring ECMO. We said the ECMO means extracorporeal membrane oxygenation. This is done to babies whose lungs are not able to circulate the oxygen or to absorb the oxygen properly. Then we have gastroesophageal reflux in 50% of the cases, and the scoliosis in 10% of the cases. This information is very important in counseling expecting parents, so that they are aware that surgical operation or correction is not the end of the morbidity pattern or morbidity story, so that they are fully informed before they make the decision to fight for the baby's life. These are the recurrent risk. The syndromes involved is very high. Then lung agenesis or hypoplasia, probably this is where we were. Occurs in 1 in 50,000. This is complete absence or hypoplasia of one lung, usually the right one, with major mediastinal shift. The incidence of chromosomal abnormalities is not increased. The association with hypoplastic right lung, with hypoplastic right pulmonary artery and partial pulmonary venous drainage of the right lung into the inferior vena cava is referred to as Schmitter syndrome. I think we did this last week. Now I remember when we were talking about Schmitter syndrome. So hypoplastic right lung, hypoplastic right pulmonary artery, and partial pulmonary venous drainage of the right lung into the inferior vena cava, which is the Schmitter syndrome. Of course, detailed ultrasound examination, including echocardiography, is required, and ultrasound scans every week to monitor the evolution of the condition. Delivery, hospital, the neonatal intensive care. Again, we can see that there is mediastinal shift as the heart is pushed to the other side here. And we can see the lung. the other lung occupying the rest of the thorax. It's a normal looking lung, but because there's no lung here, the heart is pushed to the other side. It's very important to be able to distinguish this condition from the other conditions you mentioned, things like congenital diaphragmatic hernias, and also bronchial atresia. Is very important to be able to distinguish this. So delivery time in 38 weeks. So always remember 38 weeks. 38 weeks is more like the time for delivery of most congenital abnormality babies with congenital abnormalities. Then the induction of labor aiming for vaginal delivery is recommended in this case. Prognosis is worse for right than left lung agenesis, probably because of greater degree of heart and mediastinal displacement. In Schmidt syndrome, mortality is about 10% due to severe pulmonary hypertension. The risk of recurrence is not increased. Pleural effusion. This is an isolated congenital chylothorax. It is found in about 1 in 10,000. It usually presents with pleural diagnosis at around 26 weeks of gestation. When unilateral, which occurs in about 25% of bilateral, anechoic area surrounding the lung is seen. It is subjectively divided into mild, moderate, severe, and in the later cases, there is mediastinal shift. In half of the cases, the effusion is isolated, and in other half, there is associated drops with skin edema or ascites. So this is an example of a baby with unilateral pleural effusion here. So you can see that there is a lung on the left side, and this is the heart, and the other lung on the right side. So you can see this fluid within the pleural space. So pleural effusion is not difficult to diagnose. It's easy because it's quite evident for anyone who scans in a normal way. So when chromosomal defects are associated, mainly trisomy 21, these are found in about 10% of the cases. So pleural effusion, we can only say it's isolated if a detailed anomaly scan has been done to exclude other markers of trisomies. It can also occur in cases of Noonan syndrome. Noonan syndrome is an autosomal dominant condition, but greater than 90% of the cases of Noonans are due to de novo mutation. When we are saying due to de novo, we are saying there is no precedent, there is no one in the family who had Noonans. It just comes or it just occurs. That's Noonans. That's how Noonans occurs by de novo mutation. But in certain cases, it could be due to autosomal dominant pattern. How do we recognize Noonans? There would be cystic hygromas. So if you see a cystic hygroma and the baby is a boy, you know that the differential is Noonans. It cannot be Tenans. Because in Tenans, they are girls, right? Phenotypically, they are girls. So if you see a baby boy who has cystic hygroma, remember your other differential is Noonan syndrome, not Turner's monosomy X, because monosomy X, they are girls. There is hypertelorism, there is pulmonary stenosis and fetal growth restriction. Noonan syndrome is found in 5% of cases of isolated hydrothorax. So it has to be entertained. The only challenge is that it is extremely difficult to diagnose laboratory-wise Noonan syndrome. The panels required to diagnose it are quite complex. In the case of associated hydrops, there's a wide range of genetic conditions I'm sorry, I think I lost you. My screen is coming back. Sorry about that. So let me just explain this last slide. I was saying, if you happen to come across a baby with hydrothorax or pleural effusion, you can see there's ascites. There is an echogenic cortex of the kidney and a severe hydronephrosis here. Obviously, these syndromes are more likely either dealing with the Nunans or one of the chromosomal defects. It could be trisomy 21, monosomy X, or any other defect. So associations do matter here. In severe unilateral or bilateral pleural effusion, placement of thoracomatic shunts restore the normal intrathoracic anatomy and the results in the resolution of associated eye drops and polyabdominals. In an alternative to shunting is pleurodesis, in which a sclerosing substance is injected in the pleural cavity. Then that's fetal therapy, but fetal therapy has to be offered to those with isolated pleural effusion, not those with other markers of chromosomal defects. Ultrasound scans every 2 weeks to monitor the evolution of the pleural effusion and associated eye drops is recommended here. And the insertion of new shunts may become necessary if the old ones are blocked or displaced. Again, hospital with intensive care for delivery, time 38 weeks, method of delivery, C-section if there's severe eye drops. In fetus with shunts, these need to be claimed and delivered to prevent the development of pneumothorax. So as soon as the babies come out, before probably they take their first breath, please claim the shunt. Then isolated pleural effusion, survival is greater than 90%. Most of the lungs are not overcompressed. Then effusions with eye drops, in 50% of the cases, the eye drops resolves after thoracoamnionitic shunting. And in this case, the prognosis is good. If there is no resolution of eye drops, there may be an underlying genetic syndrome or infection, and in this case, the prognosis is poor. Recurrence, isolated or associated with infection, the recurrence is nil. That means there is no increased recurrence. Then if it is part of trisomy, again 1%, part of genetic syndrome, up to 25%. Then pulmonary sequestration. How common? 1 in 15,000. Ultrasound scan identification. This will appear as an high-pay echogenic mass in the lung, mostly on the left lower lobe. Color Doppler will demonstrate a feeding vessel that arises from the descending aorta. In 75% of the cases, it is intralobar, making it indistinguishable in appearance from microcystic or CPAM. From microcystic CPAM. Remember, I showed you the CPAM condition. In 25%, it is extralobar. That means it is within the pleural space. Or it may be located outside the normal lung with its own visceral pleural. In most of these cases, there is associated pleural effusion. So this is an example of a sequestration here within the lung. See, in this case, it had caused pleural effusion and displaced the heart. This is sequestration we have here. Sometimes there may be extrapulmonary. This is one of our cases where it was extrapulmonary here with some feeding vessels. There was some demonstrative feeding vessels. I didn't find the right picture we did, but this one was power Doppler one. But this was a case of sequestration, pulmonary sequestration, and it's self-resolved actually. It wasn't found after. It shrunk as the pregnancy went on. This was 29 weeks, but by the time of delivery, it was getting smaller, and the postnatal investigators didn't find it. The incidence of chromosome abnormalities and genital syndromes also increased. Defects in other systems, mainly diaphragmatic hernia or cardiac vertebral anomalies, are found in about 50% of the cases with extralobar sequestration. Ultrasound guided laser coagulation of the feeding vessel in case of severe hydrothorax or hydrops, because sometimes they may cause high output cardiac failure. Every 4 weeks reviews to monitor the growth of the tumor and also the hydrothorax or hydrops. In greater than 30% of the cases, there is regression or disappearance of the tumor during the third trimester. This is what happened to our tumor, the baby we were following. So this is fairly common. This is one sort of message which is very reassuring to couples to tell them that it may self-resolve on its own. Then delivery, 38 weeks, and in a hospital, the intensive care and pediatric surgery. So if you know that your hospital doesn't have it, you have to refer. Induction of labor aiming for vaginal delivery is recommended. Survival, about 95% of babies live, and postnatal therapy may involve endoscopic removal of mass or selective embolization of the feeding artery. No increased risk of recurrence. Oops, yes. So I think we are done with the common pulmonary lesions. I'm not sure if we left any of the pulmonary lesions, but I think we've looked at the most common pulmonary lesions we are going to encounter in our line of work. So I think I'll end here. Things like small thorax and so forth, those will be covered under skeletal dysplasias. But the lung lesions, I think we covered what we are more likely to encounter. I think I'll leave this room for questions. I think we still have time to entertain questions. Any questions on lung lesions, the thorax and lung lesions?